Everyone, iridodialysis is a common complication noted secondary to blunt trauma or in cases of intraocular complications. My first case is of a 25-year-old gentleman who had sustained cricket ball injury 6 months ago, and he presented 6 months later with iridodialysis and subluxated total cataract. Plan was to perform lensectomy, vitrectomy, iridodialysis repair, which was there in 3 o'clock hours, and along with SFIL implantation. So we went ahead with 3-port pars plana vitrectomy. Initially, lensectomy was performed in order to clear the total cataract. Following that, PVD induction was done and pars plana vitrectomy was completed. Next step was iridodialysis repair, for which a 1.5 mm from limbus groove was made, and opposite to the dialyzed area, limbal entry was made. With the help of bent 26 gauge needle, iris root was anchored and a 10-0 double arm needle was passed. Initially, first needle was passed and iris root was anchored. It's in the similar fashion, second needle was passed and both were tied and superiorly. Following this, SFIL was implanted and haptics were exteriorized. This is of a 62-year-old gentleman who underwent cataract surgery, but the surgery was abandoned.
Ladies and gentlemen, you are not ready for this.
I was also amazed to see this clinical picture. It was an abandoned cataract surgery with iridodialysis of nearly 4 to 5 clock hours. There was a remnant lens matter present. There was grade 4 media haze due to vitreous hemorrhage, and there was central corneal edema. So two plans were there. One was suggested by an anti-segment surgeon where it could be done in a stage procedure, but we went ahead with plan B of lensectomy, vitrectomy, iridodialysis repair and SFIL implantation. So first we had to clear up the media in the pupillary area, so we cleared the lens matter from the pupillary area. Then we went ahead with 3-port pars plana vitrectomy. After PVD induction, pars plana vitrectomy was completed. Then we had to remove the remnant capsule and the attached cortical matter. One needs to be careful in this, as the lens matter is adherent in the area where there is iridodialysis, so you can take help of max grip forceps so that you do not increase the clock hours of iridodialysis. Following this, in order to pass the 10-0 proline suture, you need to make 2 limbal incisions, as we were planning to repair it at 2 sides. For 4 o'clock repair, we passed the needle through 10 o'clock limbal incision, and both the arms of 10-0 proline sutures were passed through it, and iris space was sutured with the help of 10-0 proline suture. In the similar fashion, we passed the needle from 8 o'clock limbus and it was brought out at 2 o'clock. Both the arms were sutured after exteriorization. Now we were only left at the 3 o'clock position, so we made an sclerotomy to exteriorize the haptic of SFIL. With the help of an X-nit, we exteriorized the leading haptic of an SFIL, as you can see in the video. Following this, with the help of max grip forceps, we could exteriorize the trailing haptic of the SFIL. So we could fairly achieve a round pupil and centered IOL. This was at presentation, and this is what we could achieve at 1 month follow-up. Thank you for watching.